Greetings everyone. My name is Louin Jose. I work as an assistant professor at Yenepoya School of Allied Health Sciences, Yenepoya deemed to be university. The topic that I'm going to discuss and describe with you is on adaptive support ventilation. Now, since this adaptive support ventilation mode is owned by Hamilton and it's a proprietary mode, I would want to say that I have no conflict of interest to disclose. Before we jump into the topic, I have some prerequisites that I would like you to cover so that you can listen to my lecture without limiting your understanding. You need to understand some of the basic respiratory physiology, the concepts of gas exchange and V/Q mismatch, fundamental concepts of mechanical ventilation, such as conventional mode of ventilation, concepts of closed loop and open loop ventilation, basic understanding of pathophysiology of respiratory failure, such as chronic respiratory failure and acute respiratory failure, and the disease processes that leads to it, such as ARDS and COPD, clinical assessment skills of basic nature, such as using your arterial blood gas to guide mechanical ventilation, basic ventilatory management, and the concept of weaning when it comes to ventilatory management. If you have these prerequisites covered and if you have decent knowledge about all of these 5 prerequisites, you should be able to listen to my lecture without having any major learning blocks. So once the lecture is completed, you would be able to describe the history, goals, and the differences of lung protective strategy, compare it to the conventional mode of ventilation. You will be able to enumerate the indications, contraindications, and setting up of ASV mode of ventilation. You will be able to explain the working principle of the ASV and how the ASV algorithm generates a lung safety window, which is lung protective strategy that is employed in ASV mode of ventilation. You will be able to outline the monitoring, measurement, weaning, and troubleshooting of some of the commonest issues that you would face while using ASV mode of ventilation. Now, what is adaptive support mode of ventilation? Now, adaptive support mode of ventilation is a mode that automatically adapts the patient's adapts the mechanical ventilation to the patient's respiratory mechanics. Now, it doesn't solely rely on what a clinician or what an intensivist said, but rather it changes the mechanical ventilation based on the respiratory mechanics or the lung that it ventilates. And it utilizes the closed loop ventilation concept to do this. The respiratory mechanics of the patient is constantly monitored, and the ventilator would adjust the inspiratory time, the I to E ratio, tidal volume, and respiratory rate based on the lung that it ventilates. Now, to understand an ASV, which is considered as a relatively new mode of ventilation, even though the mode has been there since quite some time, we need to understand and look back into the conventional process of mechanical ventilation, what we used to do traditionally. So we intubate a patient, put a patient on mechanical ventilation, and we observe the respiratory pattern of the patient. Now, the ventilation is optimized to a specific phase of respiration, and the bulk of breathing of that specific phase of respiration is controlled to a lowest point which is possible. Now, the problem with this is the work of breathing from one breath to the other was never addressed. Now, by bringing in automation into modes of mechanical ventilation, like this mode that we are talking about, ASV, which uses automation, we are able to control the work of breathing of the patient from one breath to the other. So we have a breath to breath control over the work of breathing, and we are able to reduce the work of breathing of a breath to its lowest possible point. Now, eliminating the work of breathing completely is necessary and possible, but we are able to keep the work of breathing of one breath to its lowest possible point. Now, traditionally, this has not been done. We look at the patient's work of breathing at specific points, and then we optimize the mechanical ventilation to the observations that we made. But in this, the respiratory morphology is monitored by the mechanical ventilator, and the ventilator would then decide how to adjust the ventilatory parameters to achieve the least possible work of breathing. And that way, the work of breathing of the patient remains reasonably low. And that's what automation gives us, a breath-to-breath control, or in other words, we can say, not the specific phase of mechanical ventilation is optimized, it is the breath and the work of breathing related to that breath is optimized. So the term, the optimal ventilation, is more valid when it comes to automation. So this mode evolved as a form of mandatory minute ventilation, which was implemented with adaptive pressure control, and it was described by Hewlett in 1977. The invention, although, is credited to Dr. Flora Tehrani. She used the Otis's equation from the 1950s. Now, the first clinical application was done by Lobsher and his colleagues in 1994, but it was not until 1998 this mode became commercially available in European market. And it took until 2007 for this mode to be available in US market. Now, the key feature of this mode is this is something called as the optimal targeting scheme. So the optimal targeting scheme, which is used in this mode, makes sure that the ventilator selects a respiratory rate and tidal volume, which presumably the patient's brain would select if the patient was not connected on a mechanical ventilator. And by selecting a respiratory rate and tidal volume, which the patient's brain would possibly select, it is said to encourage the patient to breathe spontaneously. Now, unlike any other mode which is designed for a specific phase of respiration, this mode can be used in all kinds of patients, adult and pediatric, from the initial point of mechanical ventilation through the monitoring phase until weaning, as it is not designed for a specific phase of mechanical ventilation. This can be used in patients who are passive and can be used in patients who are active. Now, since ASV mode and its controls are different from the conventional mode of ventilation, we can sort of compare and contrast the controls we have in conventional ventilation and in ASV. Now, you can clearly see just in a glance that the predominant advantage that it gives, that the ASV gives in controlling CO2 elimination. In conventional ventilation, we had to control 4 to 6 parameters to achieve CO2 elimination, but that's not the case in ASV. We have one point of control, which is the person-minute volume, which controls the tidal volume and respiratory rate. And that is the goal of ASV when they designed it, to abolish separate modes for passive and active patients, to invent single point of control for CO2 elimination, that is your person-minute volume control, and to provide direct access to oxygenation control such as your PEEP and FiO2. Now, coming to indications and contraindications, the indications include adult and pediatric patients of all kinds and all pathologies. You can use it in active patients as well as in passive patients. So in a way, it is called as one mode for all. And it is also described as a no mode, as it does not have a specific character of a mode. It is also called as an integrated mode because this one mode integrates the function of 3 different modes. Now, if the patient is passive, then the mode will behave something like PRVC. So just to compare how the mode is going to behave on a passive patient to something that you're familiar with, the mode is going to behave like PRVC, where the pressure regulated volume control breaths are going to be delivered. The patient is completely passive and no spontaneous breaths are detected. Now, in an active patient, it depends on the respiratory frequency of the patient. If the respiratory frequency of the patient is more than the targeted frequency, then the ventilator is going to act like volume support. If the respiratory frequency is less than the targeted frequency, then the ventilator will allow the patient to breathe intermittently between the mandatory breaths, acting like SIMV. So you can say that is one mode for all, and the ventilator in this mode is going to move from these breath patterns flawlessly, depending on the patient's status, whether the patient is active or passive, or whether a patient who is passive becomes active. The ventilator in ASV mode, the ASV mode is going to flawlessly switch from one type of control to another type of control, which we are going to see as the slide progresses and how the mode does that. Now, the contraindications are majorly based on a leak. You cannot use it on neonatal patients. NIV is also a contraindication, and any sort of leak, whether that is coming from the machine's end where the ventilator circuits are leaking, or the endotracheal tube is leaking, or the tracheostomy tube, or if it's coming from the patient, if it's related to a bronchopleural fistula, leak cannot be tolerated, and it cannot be, the mechanical ventilation mode cannot be used in the presence of leak. So the contraindications are, once again, neonatal ventilation, NIV, and any sort of leak, whether that's from the side of the patient, such as bronchopleural fistula, or whether that's from the side of the ventilator or from artificial airway. Now, to describe the key feature of this mechanical ventilation mode, which is the optimal targeting scheme, I have to introduce the work which is done by Dr. Ran Fenn in 1950s and 1956. So you can see this graph. On the horizontal x-axis you have the respiratory frequency, and on the vertical y-axis you have the rate of work, and you can see the total work curve. All the way at the top you have the elastic work component and the inelastic or the resistive work components, which includes the viscous and the turbulent components there. Now, if you imagine there is a respiratory rate which gives you the least amount of work of breathing, if you think intuitively, if you try to breathe slowly, is that going to make the work of breathing low? And that's what Dr. Otis had done. And Dr. Otis said if the work of breathing is going to be low, the respiratory frequency is going to be low, the work of breathing is going to be high, and that's because of the elastic workload. Now, when someone breathes low, to achieve the specific target minute alveolar minute volume or minute ventilation, such as in this diagram, it's given as 6 with a dead space of 200 ml. Now, in that case, if someone breathes at a very low frequency, he has to overcome the elastic forces of the lung. So the work of breathing of that patient who is breathing at a lower frequency, somewhere between 5 to 10 breaths per minute, his work of breathing is going to be high. And the work of breathing is high because he is spending energy to overcome the elastic forces of the lung. In order to breathe with low frequency and achieve the same minute ventilation, the individual has to raise the tidal volume. And that way the elastic workload increases and the total work of breathing stays high because of the elastic component. Now, if you imagine someone who is breathing at higher frequency, his work of breathing is going to be high as well, and that is because although the elastic forces are low, the inelastic forces are at its highest. The viscous forces are at its maximum, and the turbulent flow and the forces related to the turbulent flow are at its highest as well. So now we can summarize that if someone breathes at lower frequency, he has to breathe high tidal volumes, and because of that, his work of breathing is going to be high as the elastic forces are going to be at its maximum. Now, conversely, if someone is breathing at high frequency, his work of breathing is going to be high. That's because the inelastic forces are at its highest, such as the resistive forces, which is contributed by your viscous forces and the turbulent. So, breathing at lower frequency, the work of breathing is high, and breathing at higher frequency, the work of breathing is high. In low frequency, it is because of the elastic force, elastic workload, and in higher frequency, it is because of the resistive force or the resistive workload. So there has to be a respiratory frequency right in between where the elastic forces are its lowest and the viscous forces and the turbulent forces are also at its lowest. Brain, being an energy efficient organ, will choose a respiratory frequency which gives us the least amount of energy expenditure. So that respiratory frequency in this case of a minute volume of 6 and a dead space of 200 ml is going to be 15 breaths per minute. Now the ventilator in using the ASV mode is able to calculate this optimal frequency which Dr. Otis has described. Now breathing at that optimal frequency is going to offer the less amount of, or the least amount of work of breathing. Now in this diagram we can see this is how the ventilator plots the graph. Now the curve that you see here, the light blue curve, these are the permutations and combinations of tidal volume on the y-axis and respiratory rate on the x-axis, which the patient can use to achieve a minute volume of 7 liters per minute. Now, ventilator has calculated the optimal point of ventilation where the work of breathing is at its lowest, and that is a respiratory rate of 16 and a tidal volume of 400 ml. Now here you can see that's the current respiratory rate and tidal volume of the patient. Now if the patient keeps breathing at this point, the patient has slightly higher work of breathing. So the ventilator is trying to guide the patient's respiratory rate and tidal volume to this point where it matches with the respiratory rate of 16 and a tidal volume of 434. Once the patient's minute ventilation matches to this point, the patient is said to be optimally ventilated. Now at this point of optimal ventilation, the work of breathing is going to be at its lowest, as I had mentioned, and the oxygen cost of breathing is also will be at its lowest. Now how does the ventilator calculates this? And the ventilator calculates this by using the Otis's minimal work equation, and this is the equation which Dr. Otis was developed and later was modified by Dr. Mead. And here you can see the components of Dr. Otis's equation. So we have the respiratory rate, we have RC, which is the time constant, which is calculated by multiplying the airway resistance to the lung compliance. We have min vol, which is the minute ventilation, VD, the dead space, which is calculated as 2.2 ml per kilogram of ideal body weight. Now to factor in the sinusoidal flow, we have added a constant, which is this constant A, which is going to account for the sinusoidal flow which the patient is assumed to have. So the ASV algorithm uses Dr. Otis's equation, which is modified by Dr. Mead. And this is how the mode actually works. So just to describe to you using this flow chart. So as an intensivist or the respiratory therapist, as he enters the height of the patient, the suggested or the required percent minute volume the patient requires, dials in the PI max, the PEEP and the FiO2, and clicks start ventilation. The mechanical ventilator is going to perform two functions. It is going to measure the respiratory mechanics, and that is the compliance resistance and if there is autopeme, it is going to measure all of that. So it basically maps out the lung that it ventilates. From the respiratory mechanics, the ventilator is going to determine the inspiratory pressure which it can safely use. Alongside, it plots a flow volume curve. And with the help of the flow volume curve, it calculates the expiratory time constant, which describes how fast that particular lung empties. Now, I'm sure that you're familiar with the concept of time constant. Time constant is calculated by multiplying the lung airway resistance to the lung compliance. Now we know that resistance is calculated by change in pressure, by change in airflow, and the compliance is calculated by change in volume, by change in pressure. So pressure and pressure cancels out. We have flow and volume. The flow is in ml per second and the volume is in ml. So the ml gets cancelled and we have respiratory time constant, thus calculated in seconds. Now, thus calculated respiratory time constant, or the expiratory time constant, that expiratory time constant is inserted into the equation. Once inserted, the equation by Dr. Otis modified by Dr. Mead is going to calculate the optimal frequency. So the optimal frequency is calculated by Dr. Otis's equation. So this frequency is going to give us the least amount of work of breathing for the process of respiration, depending on the patient's lung. Now, by dividing the minute volume of the patient by the respiratory frequency, the ventilator then comes up with the targeted tidal volume. Now, the point where the targeted tidal volume meets the respiratory frequency is the optimal point of ventilation, where the work of breathing is at its lowest and the oxygen cost of respiration is also at its lowest. Now, we can see that if we sort of draw this line, it divides this whole graph into 4 quadrants. Now, patient is able to breathe within this quadrants, but patient cannot be or can't be allowed to breathe with higher volumes or either lower volumes. Patient cannot be allowed to breathe with extremely high respiratory rates or extremely low respiratory rates. We need to have boundaries within which the patient should be allowed to breathe safely. And the ASV mode of ventilation, thus using these equations that you see, is going to generate something called as a lung safety window. And patient is allowed to breathe within this lung safety window. Now the top of the lung safety window controls the maximum tidal volume the patient can safely inhale. And that is majorly based on the PSAV limit that you will set. It's also based on this equation, which is 1.5 times the set high alarm limit of the patient, and also this equation, which is derived from the equation of motion, where the PSAV limit is subtracted from PEEP and accounted for the compliance or the dynamic compliance of the lung. Now that's how the maximum amount of tidal volume the patient can safely inhale is determined. And this point A, will prevent the patient from going into barotrauma and volutrauma. Now, patient cannot be allowed to breathe at extremely low tidal volumes, for which we have this low point here, which controls the least amount of tidal volume patient can safely breathe, and that is based on the dead space of the patient. So a volume twice that of the dead space of the patient is used. So dead space in this mode of ASV is calculated as 2.2 mLs per kg of ideal body weight. So 4.4 times ideal body weight, although it is little high, is enough to prevent dead space ventilation. So it prevents low alveolar ventilation, dead space ventilation, and prevents possible atelectasis. A patient cannot be allowed to breathe at too low of respiratory rate or too high of respiratory rate. So the apnea is controlled by this portion, which is set as default at 5 breaths per minute. Now, if the patient that you're ventilating, if that patient is about 3 kgs, then this would be reset to 14 breaths per minute. Okay, so that is a default setting. Now, the high respiratory rate the patient can possibly breathe is designed based on the equilibrium point equation. So, where our 2-time expiratory time constant is enough for the lung to reach the equilibrium point, where 90% of the potential gas generated during inhalation can be exhaled out. So 1-time constant for inspiration and 2-time constant for expiration multiplied by the expiratory time constant, which gives you 20 divided by expiratory time constant, will make sure that the patient's respiratory frequency, which the high respiratory frequency which is set, does not cause dynamic hyperinflation or breath stacking. Now, thus a created lung safety window serves as a safe boundary within which the patient can be safely ventilated. Now, you can see the lung safety window is divided into 4 quadrants. And right at the center, you have the optimal target of ventilation, where the work of breathing is presumed to be low. The patient is able to breathe freely within this lung safety window, within all these quadrants. Now, let's imagine a patient breathing at this quadrant, the right upper quadrant, where the tidal volume of the patient is high and the respiratory rate of the patient is high. Now, breathing at this point, it's no longer optimal. Now, the ventilator tries to guide the patient slowly to this optimal point. Now, how does the ventilator do that? The ventilator is going to drop the inspiratory pressure, that is going to progressively bring the patient's volume, and at a certain point the patient's tidal volume is going to meet the targeted tidal volume. Now, the ventilator is going to drop the respiratory frequency of the patient slowly and progressively. That's going to bring the respiratory frequency of the patient closer to the optimal respiratory frequency. Now, once the patient's tidal volume and respiratory rate meets this point of optimal ventilation, the patient is said to be optimally ventilated. Now, like so, if you imagine a patient breathing at this point, where the tidal volume is low but the respiratory rate is high, to guide the patient to the optimal ventilation point, the ventilator increases the pressure. The low tidal volume of the patient is slowly raised until it meets the targeted tidal volume. The respiratory rate of the patient is slowly reduced until it meets the targeted respiratory frequency, and the patient comes in line with the optimal point of ventilation. Now, conversely, all these quadrants are addressed by the ventilator as well. Patient breathing in this quadrant where the tidal volume is high and the respiratory frequency is low, ventilator drops the inspiratory pressure, brings the tidal volume of the patient closer to the targeted tidal volume, increases the respiratory frequency, and brings the patient's respiratory frequency closer to the optimal respiratory frequency. So, as in this quadrant as well, where the patient's tidal volume is low and the respiratory rate is low as well, ventilator increases the inspiratory pressure. That brings up the tidal volume of the patient to the targeted tidal volume. Ventilator increases the respiratory frequency, and that brings the respiratory frequency of the patient closer to the targeted respiratory frequency. Now, to talk about briefly on how to set up this mode, like any other mode, you would want to calibrate the mechanical ventilator along with the ventilator circuits and any adjuncts like heat moisture exchangers or active humidifiers that you're going to use along with the patient's mechanical ventilator circuit. Now, this is how the ASV standby screen looks like. Now, you would select the patient type, adult or pediatric, select the mode as ASV, select the gender of the patient, and then you have to rightly enter the height of the patient, from which the ideal body weight will be calculated using the Radford's nomogram. By clicking the controls, you will be able to set the following factors, such as your percent minute volume, as much as the patient requires, the PEEP, and the FiO2. After which you can go to the basic settings and then set the PSAV limit and the suitable trigger setting for the patient. Once that is set, you can go to the more settings and then select a suitable ramp time for the patient and a suitable expiratory trigger sensitivity. Now, if your patient has obstructive pathology, then the expiratory trigger sensitivity should be set somewhere between 35 to 45%. But this needs to be looked at. It has to be set based on the respiratory morphology, inspiratory time, the total cycle time, etc. Now, just to explain the percent minute volume setting, which is one of the predominant setting in this mode of mechanical ventilation. So, an initial recommended setting, if you have a patient with a normal lung, you can set the patient with normal lung at 100%, which will be calculated as 0.1 liters per kilogram of ideal body weight. Now, in pediatric population, that's going to be a range. It will be set between 0.3 to 0.1 liters per kilogram of ideal body weight. Now, if you wish to convert the percent minute volume setting into minute volume in liters per minute, you can use the following equation, where the minute volume is multiplied by the ideal body weight and then it is divided by 1000. Now, if you imagine a minute volume of 100, as in the case of a patient with normal lung, and an ideal body weight of 70, so 100 times 70, you have 7000 divided by 1000, which gives you 7 liters per minute of minute volume. Like so, if your patient's body weight, if a patient's ideal body weight is between 3 to 15, then you can use the following equation, where you're going to divide by 500 instead of 1000. Now, just to give you a reference starting point, based on patient's lung pathology, if you have a normal patient, if you have a patient with chronic hypercapnia, or if you have a patient with brain injury, you can start the percent minute volume at 100%. In case of ARDS patients, and in patients with ARDS and chronic hypercapnia, you can start at 120%. Now, along with the percent minute volume, you have to also check whether there are special factors that comes in which requires adjustment of the percent minute volume. If the patient has fever, the percent minute volume has to be increased by adding 20%. Now, if the patient is being ventilated above sea level, then the percent minute volume should be increased by 5%. So you have to add 5% to the already calculated or suggested or recommended or the already decided percent minute volume. You have to add 5% to it. Now, if you're going to use a heat moisture exchanger, you have to add 10% to it. Now, your PEEP and oxygenation control, you can start at a suggested value. You can also use the ArtsNet protocol, or the Hamilton ventilator provides you with the PV tool, which can be also used to set the PEEP and FiO2, or basically the oxygenation controls. Now, once you have selected and adjusted all of these, you have set the maximum pressure, the flow or pressure trigger is selected, you have selected a suitable ramp for the patient, the expiratory trigger sensitivity is adjusted to match the patient's respiratory mechanics. You can click start ventilation and ventilator will start providing the patient with the breaths. Now, alarms need to be adjusted. For a normal patient, who is being ventilated at 100% minute volume, you can set the high pressure alarm limit at 40 centimeters of water. And what's that going to do is it is going to set the PSAV limit at 30 centimeters of water. Now, while setting this, you have to be careful because 1.5 times the high pressure alarm limit, the ventilator is going to terminate the mechanical breaths. You should also note that changing the PSAV limit is also going to change the high pressure alarm limit as well. Now, this is just to give you a short summary and a point of reference so that you can start off and start ventilating the patient and you're not confused what percent minute volume to set. You can use this as initial reference point for percent minute volume and PSAV limit and oxygen starter points. Although I would stress that this needs to be adjusted as soon as possible if the patient requires more support or even less support. So based on the patient's requirements, this has to be adjusted, even though this is given as the suggested reference, just to be used as a reference point. So just to remind you that if the patient has fever, if the patient is ventilated above sea level, or if you're using a heat moisture exchanger, the suggested additions has to be followed. Okay, when it comes to monitoring in ASV, it is quite plain and simple. All you have to do is you can monitor the expiratory time constant, which describes how fast or how slow the lung fills or empties, and you get a really good picture of the respiratory mechanics of the lung that you're ventilating. Now, if you have a stiffer lung, someone with a restrictive disease, the expiratory time constant is going to be shorter, and that means it is going to be less than 0.6. Now, if you have a patient with a normal lung, the expiratory time constant is going to be between 0.6 to about 0.9 seconds. Now, if you have someone with a long expiratory time constant, you're ventilating a patient with obstructive disease. So by using the lung safety window and the shape of the lung safety window, using the expiratory time constant along with it, you will be able to understand the respiratory mechanics of the lung just in a glance. So if you have a wide square-shaped box, you're ventilating a patient with normal lung, you can also see the expiratory time constant is at 0.6. Now if you have a low wide box, you're ventilating someone with a stiff lung, someone with a restrictive pathology. Now here the expiratory time constant is 0.3. As the lung is stiff, the gas that goes in comes out really fast. So the expiratory time constant, how fast the lung empties, is quite short. Now if you have a narrow high box, you're probably ventilating someone with an obstructive pathology, maybe bronchospasm, COPD, maybe the enterotracheal tube is kinked or blocked by secretions or mucus plug. This could possibly give you this pattern, and also a expiratory time constant that is more than 0.9. Here it's 1.2. So a narrow high box shows you that the patient might have an obstructive pathology of some sort, or maybe something wrong with the artificial airway. So high resistance because of the artificial airway, secretions, tube bites, kinks, or maybe you are ventilating a patient with obstructive pathology, bronchospasms, COPD patients, etc. Now if you see a low narrow box, you're ventilating a mixed pathology where there is high resistance and low compliance. So you can see how easy this is just by looking at the shape of the lung safety window and referencing the expiratory time constant along with the lung safety window. Just in a glance, you're able to understand the type of lung that you're ventilating. Now to talk about managing oxygenation and ventilation. Managing oxygenation and ventilation in passive and active patient is quite straightforward and simple as well. Now if the patient is passive, then the ventilator is going to behave like a pressure controlled mode of ventilation and it's going to deliver pressure controlled breaths. And if the patient is active, it's going to provide the patient with pressure supported breaths. So in a passive patient, it provides pressure control. Active patient, it provides pressure supported breaths. Now, if a passive patient builds up CO2, then all you have to do is increase the person-minute volume. Now, if the CO2 is too low, then reduce the person-minute volume. Now, in an active patient, if the active patient is tachypnic, then increase the person-minute volume support. Now, if the active patient's respiratory rate is lower or the pressure support is higher than desired, then you simply decrease the person-minute support. So it's pretty straightforward and simple, but also you should keep in mind that you should never cross a person-minute volume of 300%. The range allows you to go from 25% person-minute volume to about 350% of person-minute volume. Although typically we usually stay between 70% to 200%. These are the person-minute volume that are used clinically. Now, if there is a requirement to go above a person-minute volume of 200, you must consider the following factors, such as reducing the basal metabolic rate by managing fever, sepsis or acidosis, or by increasing sedation. Now, how precisely to adjust? So, in a passive patient, if the PCO2 is high and the arterial pH is low, then you increase the person-minute volume in steps of 10 to 20% until you restore the normal PCO2 and arterial pH. Now, in an active patient, if the active patient shows continuous signs of respiratory distress, then you increase the person-minute volume in steps of 20. Make sure that you wait for 2 to 5 minutes between your each adjustment. Now, if the patient is active and the spontaneous breathing disappears or becomes irregular, try reducing the person-minute volume in steps of 10. Now, observe the patient's response in between your adjustments, and that is crucial. Now, to assess the readiness of weaning, you have to make sure that the reason for intubation and for the initiation of mechanical ventilation is completely resolved. You have to have the arterial PaO2 more than 60 millimeters of mercury with an FiO2 requirement of less than 0.4. Patient has to be hemodynamically stable, clinically stable with adequate respiratory efforts and bilateral equilibrium entry. Patient has to be weaned off from sedation, has to be oriented, has to have adequate level of consciousness. If that's confirmed, you can move on to weaning. Now, weaning is done in 3 separate phases. So in phase 1, the patient undergoes screening where you're slowly reducing the person-minute volume. You're going to reduce it to up to about 70%. You're also reducing the PEEP and FiO2, and you're doing this every hourly. Once you reduce this to a person-minute volume support of 70%, you're going to move on to the observation phase, where the patient's respiratory rate, PEEP requirements, oxygenation requirements are going to be observed. The patient's respiratory rate has to be less than 30 breaths per minute. The inspiratory pressure has to be less than 15 centimeters of water. The PEEP requirement has to be less than or equal to 8 centimeters of water. And the oxygenation requirements has to be less than or equal to 40%. Now, if the patient can maintain on these variables and values for about 30 minutes to 2 hours, you can consider switching the patient to a spontaneous breathing trial. Now, during the spontaneous breathing trial, you're going to have the following settings. With a PEEP of 5 centimeters of water, you're going to dial the oxygen to 30% and the person-minute volume to about 25%. So, the person-minute volume of 25% is roughly about 5% of pressure support. So if the patient can maintain a PEEP of 5, oxygen requirement of 30%, and a minute volume percent of 25% for 30 minutes, you can consider extubating this patient. Now, this is how the weaning graph looks like. First is the screening phase, where you're slowly reducing the person-minute volume, PEEP, and the FiO2. You're doing that every hourly. Once the person-minute volume is brought down to about 70%, you move on to the observational phase, where we are looking at the respiratory rate. That has to be less than 30 breaths per minute. The inspiratory pressure has to be less than 15 centimeters of water. The PEEP requirement has to be less than 8, and the oxygen requirement has to be less than 40%. Now, if the patient is stable in phase 2, the observational phase, for about 30 minutes to 2 hours, you can move on to the spontaneous breathing trial phase, where the patient will be set on a ventilatory setting of PEEP of 5, FiO2 of about 30%, and the person-minute volume setting of about 25%. Patient stays stable in phase 3, then you can consider extubation. Now, the stability of the patient can be observed by using these bars. So they are divided into oxygenation, CO2 elimination, and spontaneous activity. Now, all of these floaters, if they remain in this sky blue region, a counter will start. Now, the counter is going to go and count the time till 30 minutes or 2 hours. So if the patient remains in this sky blue region for about 30 minutes, you can consider weaning of the patient. Now, just to describe some of the commonest troubleshooting that you might encounter while using ASV mode of ventilation. So during ASV mode, bronchoscopy cannot be performed on ASV mode of ventilation, because once you're going to do the bronchoscopy, it's going to introduce leak into the circuit, and that's going to affect your respiratory mechanics measurement and expiratory time constant measurements, which means that the algorithm will not be able to function. And because of which you have to switch the patient to a different mode, a pressure control mode or an SIMV or some mode that you're comfortable with, and then switch back the patient once the bronchoscopy is completed. Now, in cases where the tidal volume is very low and the respiratory rate is very high, check the PSAV limit, try to increase it. Maybe the PSAV limit is limiting the tidal volume, and also check the plate pressures as well. The tidal volume is too high and the respiratory rate is too low. Check the artificial airway for bites, kinking. You can also check the HME and make sure that the HME is not blocked with secretions or water content, or which is basically condensate. Now, just to give you a quick summary, so once you have set up the mode and you're ready to ventilate, you basically look at the patient's respiratory effort and how that effort is. If the spontaneous effort is more than the target effort, then you escalate. Okay, so and if the PSU2 is more, then you can escalate. You will escalate the person-minute volume in increments of 20%. Making sure that you're not going above 200%. Now, if that's not the case, the spontaneous breaths are not detected, and if the PSU2 is less than 45, then you have to de-escalate, reduce the person-minute volume by 10%, and make sure that you are limited to 25%. You have to do this gradually, making sure that you're providing about 3 to 5 minutes between each adjustment, or you're giving sufficient time depending on the patient's status between each adjustment. Now, if the patient is stable more than 60 minutes, then you have to look at the oxygen requirement and PEEP requirement. If the oxygen requirement is less than 40% and the PEEP requirement is less than 8, you look at the inspiratory pressure. The inspiratory pressure is less than 10 centimeters of water, you can consider extubating this patient. If that's not the case, then try to slowly wean off the patient in increments of 10% reduction from the set person-minute volume. Now, to quickly summarize, ASV mode automatically adjusts the ventilatory settings based on the patient's breathing pattern and needs, promoting efficient ventilation while minimizing respiratory muscle fatigue. The mode aims specific target variables such as tidal volume, minute ventilation, based on the patient's condition, which helps to optimize oxygenation and carbon dioxide withdrawal. ASV allows spontaneous breathing, enabling the patient to breathe independently while receiving support, which can enhance comfort and reduce anxiety during mechanical ventilation. Now, the system continuously monitors the patient's respiratory efforts and adapts the support provided, ensuring that mechanical assistance aligns with the patient's requirements. ASV is suitable for various patients, including those with varying degrees of respiratory distress, making it a versatile option in critical care setting. So these are my references if you wish to read further on this topic, and thank you.